Hello and welcome to a podcast series by Pacesdiaries.uk. This podcast is focused towards catering all the necessary information about MRCP UK and MRCP Ireland PACES exam for those who are preparing for and also for those who wants to know what PACES is all about. I'm your host, Dr. Sophia Aldrine, and today we are here to discuss yet another interesting topic in neurology. Before we proceed, let's extend a warm welcome to our guest for today, who is none other than Dr. J. Wesley. Thank you for joining us today, Dr. Moses. We are glad to have you with us again.
Yeah, thank you so much. It's been after quite a long time we are starting our podcast series, and all of us, were tossed around with a lot of works and work-related assignments and programs, and now we are relatively free to sit for a podcast. I'm really happy about that. And this is the last podcast, I think, for the neurology topic we are doing. And after this, we're going to have a weekly podcast, weekly case discussion, where we're going to discuss some acute medicine scenarios and some general internal medicine scenarios, including some scenarios from subspecialties. And I'm very excited to start the next podcast here with stroke, which is a very important topic when it comes to MRCP UK PACES, and as well as your day-to-day medical practice. Yes, here we go.
Yes, doctor. So as you just mentioned now, we are diving into one of the most frequently encountered and high-yield topics in the neurology station. And this is our last topic for neurology station, that is stroke. Stroke cases are a staple in not just the neuro station, but you can encounter in consultation station as well, where candidates are expected to demonstrate their ability to localize lesions and to interpret findings. So let's start our discussion for today, doctor. What is a clinical approach to a case of stroke in acute medical setting?
Okay, that's a very important question. Anyone should know once they get a bleep, like they have to go ahead and take the stroke patients. And some trusts have the dedicated stroke medicine unit, but sometimes it may be running full. So acute medical registrar has to go ahead and pick the case. So what they have to do, immediately you check for airway, you check for any verbal response to pain, or the patient is unresponsive, AVP you approach. And then again, your A, B, C, D, E, you have to do, which everybody knows. I'm not going to go ahead and touch in that. All right. So once it's done, just, if the patient is unconscious or anyway, the first test you have to do is check the patient's blood glucose. It's quintessential. And if you're aware of NIH's stroke scale, go ahead with that. It's available across all the trust. Okay, you need not memorize that. Nobody can memorize that. Okay, you can take a look at that and you can mark the NIH's stroke scale. And again, if the patient is unconscious, it's wise to give a single dose of ceftriaxone. Many trusts recommends that. Okay, many trusts recommends that because to decrease the risk of any ventilator-associated pneumonia. Okay, then immediately as soon as you have to go for an NCCT, all of us know. Then apart from that, you have to connect with the two large IV bore cannulas, electrocardiography, give the CBC, echo, troponin, PTINR, and APTT. The next set of investigations, all of us know the electrolytes and blood urea nitrogen or metabolic profile, your liver function test. Toxicology screen is extremely important. So the blood alcohol levels and pregnancy test, especially in a women of childbearing age, atrial blood gas, chest x-ray, and EEG if it is needed. All right. If fluids, better to give isotonic saline. All right, because the hypotonic saline or anything, if you try to push into the patient, it can exacerbate cerebral edema. All right, glucose can tremendously worsen the pre-existing hypoglycemia. So ischemic stroke, of course, when you're checking the vitals during the ABCD approach, if you're going for a thrombolysis, typically set the BP, that is systolic blood pressure, less than or equal to 185, and diastolic less than or equal to 110. If you're not going to go for a thrombolysis, the BP target should be more than 220 for systolic and more than 120 for diastolic. And if you want to lower the blood pressure, the choice drugs are your labetalol, nicapridine, and clinidipine. That's the drug that you have to go ahead for. So once you're done with that, then you're starting your approach. So what you're going to see is whether the patient knows when was the last time he's known to be well. That's extremely important. Okay, that's extremely important. Based on that only, you're going to do a lot of things in an acute medicine setting, even as a stroke registrar. So if the patient is presenting with less than 4.5 hours, all right, immediately get a stat brain imaging, usually with a non-contrast CT scan. Okay, if the brain imaging excludes hemorrhage, all right, okay, then a thrombolysis can be started within 4.5 hours. If there are no exclusion criteria, you can go for an IV thrombolysis. If the last known to be well time is around 4.5 to 24 hours, we go for an MRI, a diffusion weighted or a perfusion weighted MRI. Okay. And if the diffusion weighted or perfusion weighted MRI is kind of negative, or if suppose you're finding, a salvageable brain tissue by an automated perfusion imaging, and IVT can be started. If there are no exclusion criteria for thrombectomy, you have to consider that also. At this point, I will tell you about what is a thrombectomy and how we have to do the thrombectomy as well. All right. So this is the first thing you have to do. Then make sure the patient INR is stable, APTT is stable, and the patient is not hypoglycemia, that is his blood glucose is not less than 50 milligram per deciliter. And all these things you have to start. If possible, a quick history, rule out the contraindications, then go ahead for thrombolysis or thrombectomy based on the patient's imaging and the time zone as well. Okay. Yeah, that's how we approach. This is the quick gist of what to do immediately in the acute medicine settings.
Yes, doctor. One important thing to keep in mind is the time when the patient was last observed to be well. So thank you, doctor, for mentioning the key principles of thrombolysis and regarding the timing as well. So there's a useful tool called the NIH stroke scale that you mentioned while explaining about the thrombolysis and acute medical management, or
Exactly.
NIHSS, which the clinicians use to assess the severity of a stroke. Can you please elaborate on this, doctor, for us?
Yeah, typically the NHS score is something that's used tremendously across all the trust here. Like scale is used tremendously. Okay, it's around, we are going to look around in that for around 15 items. Okay, and typically I will describe some very important things which one should be looking around in NHS stroke scale. All right, this is a National Institute of Health stroke scale, or NHS stroke scale. If the score is going to be 0, there's not going to be any stroke. 0 to 4, minor stroke. 5 to 15, moderate. 16 to 20, moderate to severe. 21 to 42, severe stroke. Some of the key components I'm going to tell you. Number 1 is the conscious level. Is he answering to the questions or commands? And second, look for the best gaze. 3, look at the visual. 4, look for any facial palsy. 5, motor arm. 6 is your motor weakness of your patient's leg. And then again, any limb ataxia. 8, sensory. 9, what is the best language parameter? Okay. And you have to keep looking all these things in a quick succession. All right. Sensory, language parameter, and then any extinction and inattention. Formerly, you called it as a neglect. Now we are not using the term neglect anymore. Okay. Instead of using the term neglect, we are using extinction and anything is there. We need to quickly look at the patient. Also, any dysarthria is there. You have to look at that. Once you are able to look at all these parameters, then you have to just quickly make the scoring. This is very important when you receive a stroke patient, and you need not remember all these things. No one can remember all these things in an acute setting. That is for sure. Okay, because every scoring has a sub-scoring. For example, like, if you are going to look at the motor arm, left arm, like, you have to check no drift is there. Okay, if he's able to push against the gravity, not against the gravity, no movement at all, or an amputated joint, everything you have to mark out and get the scoring done at the earliest. This is the first. Second thing you have to do, this NAHSS stroke scale is quintessential. There will be a list available there. There will be a chart available there. You have to quickly mark it and get the scoring done. Yeah.
Yes, doctor. That was a clear and informative explanation of NIHS stroke scale. And I'm sure that our listeners have understood it very well. Now that we have covered thrombolysis, could you please guide us on how to approach a case for thrombectomy? What are
Okay.
the key steps a candidate should keep in mind when considering this intervention?
Yeah, that's this is very important because nowadays thrombectomy is being asked even in the Viva, and as well as a lot of trusts are doing thrombectomy. Earlier, there was a concept you cannot do thrombectomy if the last known time to be well is beyond 6 hours. Now it's not like that. Up to 24 hours, you can go ahead with that if the penumbra and core infarct volume is absolutely fine. So what you have to do, you're suspecting an ischemic stroke, and the time last known to be well is less than 24 hours, and NIHS score is more than 6. See, yes or no? If it is no, then there is no need for mechanical thrombectomy. If it is yes, obtain an urgent brain imaging. Typically, the best imaging is going to be your diffusion weighted or perfusion weighted imaging. All right. And any obstruction is there, yes or no, you see. See, suppose if the stroke is due to posterior circulation, large vessel obstruction, then go for mechanical thrombectomy. Okay, if there is an obstruction, otherwise you have to see whether the brain imaging actually excludes a hemorrhage and the aspect score is going to be more than 3. The patient can start treatment, that is a femoral puncture, okay, within 24 hours of the time last known to be well. Okay, if there are any reasons to withhold the mechanical thrombectomy. So what are the reasons at this point to withhold a mechanical thrombectomy? Any presence of large hypodensity, okay, on a HCT. If there are no ischemic penumbra, that means there are no salvageable tissue. If there are no salvageable tissue, there is no point in going and retrieving a thrombus. Okay, or if there is any presence of a large core infarct volume that is more than or equal to 50 ml on advanced imaging. Okay, if it is no, then there is no mechanical thrombectomy. I mean, like if the reasons are not there, then you can go. If the reasons are there, you cannot go for a mechanical thrombectomy. If the reasons are not there, you can obviously proceed with a mechanical thrombectomy.
Thank you so much, Doctor, for those informative comments. This explanation has truly helped break down a complex topic relevant for PACES preparation. I hope our listeners have clarity on both thrombolysis and thrombectomy now. After discussing thrombolysis and thrombectomy, can you please help us understand the main criteria for offering thrombolysis as well as situations where it's contraindicated?
Yeah, the thrombolysis offering I had already explained. I will tell you some of the exclusion criteria for thrombolysis. This is a common question that is asked in the PACES examination. So the patient history, first of all, if there is an ischemic stroke or severe head trauma in the previous 3 months, if there is any previous intracranial hemorrhage, if there is any intraaxial intracranial neoplasm, if there is any gastrointestinal malignancy, if there is any gastrointestinal hemorrhage in the previous 21 days, if there is intracranial intraspinal surgery within the prior 3 months. These are your patient history. Quickly, you have to take to the patient attendant probably because the patient may be unconscious in such a scenario or may not be able to be in a situation where he can actually provide you this history. Then again, the clinical. If there are any symptoms suggestive of subarachnoid hemorrhage, no thrombolysis. Any persistent blood pressure elevation, I told you 185 on 110, systolic and diastolic. Then any active internal bleeding. And if there is a presentation consistent with infective endocarditis, and the stroke known or suspected to be associated with an aortic arch dissection, there are any acute bleeding diathesis, including but not limited to conditions defined under hematologic, any acute bleeding diathesis. All right. Then some hematological criteria is there. If the platelet count is less than 100,000 cubic millimeter, and the current anticoagulation use with an INR of more than 1.7, or a PT of more than 15 seconds, or an APTT of more than 40 seconds. Or if there is going to be any therapeutic low molecular weight heparin given within the 24 hours for the treatment of VTE or an ACS or whatever it is. Okay. Or if there is a current use of any direct thrombin inhibitor or direct factor 10A inhibitor with the evidence of anticoagulant effect by laboratory tests such as, APTT, APTNR, and all the stuff. And in the radiological aspect, if there isn't any evidence of hemorrhage, it's going to go against thrombolysis. And if there is any extensive regions of obvious hypodensity, okay, consistent with irreversible injury, that's the same thing what we have seen for the thrombectomy. If you're going to find all these things, then it's better not to go ahead for thrombolysis.
Okay. That was a very clear explanation on the indications and contraindications for thrombolysis, Doctor. It was very incredibly informative, and it really highlights the importance of careful patient selection in stroke management. Now, moving on to the types of stroke, particularly focusing on anterior versus posterior circulation. Can you share your insights on how anterior and posterior circulation stroke differ in presentation and management?
Absolutely. This is a very important question. And we have to answer this because a lot of candidates have confusion on whether it's an anterior circulation or posterior circulation, especially candidates who don't have, proper structured internal medicine training. They will a lot fumble in this thing. So this goes back to your basic anatomy, the blood supply to the brain via the circle of Willis. You should know what is the basic anatomy, what's the basic blood supply to the brain. So what are the vessels involved? So there is an anterior cerebral artery, middle cerebral artery, posterior cerebral artery, penetrating vessels, and vertebrobasilar vessels. So you need to know what happens when these arteries are affected. For example, if there is an anterior cerebral artery is affected, there will be motor or sensory deficit where it will be more in the lower limb than the face and arm. There can be primitive reflexes like grasp reflex, suckling reflex can be present. There can be paratonic rigidity, gait apraxia, and abulia. These things can be there. Coming to the middle cerebral artery, I don't need to tell because everybody knows dominant hemisphere, aphasia, and the face and the arm affected more than the leg and the foot. All right. There can be homonymous hemianopia. Okay. That can be complete hemiplegia, what we call as a dense hemiplegia if internal capsule is affected. All right. If the non-dominant hemisphere is affected, there can be neglect, anosognosia, and motor and sensory deficit. Again, going to be more in face and arm compared to the leg and foot. Coming to the posterior circulation, it's going to present entirely a little different. We're going to see some stroke syndromes where we're going to discuss this more. And here, if you carefully see, in the case of a posterior cerebral artery issue, there's going to be a homonymous hemianopia. There's going to be alexia without agraphia if the dominant hemisphere is involved. There's going to be visual hallucinations, visual perseverations, okay? And especially if the calcarine cortex is involved. And there's going to be sensory loss, chorioathetosis, spontaneous pain if there is a thalamic stroke, third cranial palsy, paralysis of the vertical eye movement, all right? And motor deficit if there is going to be involvement of cerebral peduncle or midbrain. Now comes to another interesting part of strokes called lacunar stroke, where the penetrating vessels are involved. Here, the patient may present with pure motor hemiparesis. That's a classical lacunar syndrome, pure sensory deficit, pure sensory motor deficit, and there is a hemiparesis homolateral ataxia, and there is something called dysarthria clumsy hand syndrome. That's one of the things. Then coming to the other artery called vertebrobasilar artery. If the vertebrobasilar artery is involved, there can be cranial palsies, cross-sensory deficit, diplopia, dizziness, nausea, vomiting, dysarthria, dysphagia, hiccups, limb ataxia, may or may not be some motor deficit. This is classical of your lateral medullary syndrome or a Wallenberg syndrome. I hope that explains that clearly.
Yes, doctor, that was a very clear and concise explanation. So from the PACES perspective, can you please walk us through the structured approach to examining a stroke patient? Like
Yes.
what are essential points to keep in mind while examining a stroke patient?
Absolutely. This is very, very important. Examining a patient who is having a stroke is quintessential. You should know what to examine and you should know what to exactly look at the patient and what exactly to see in that particular patient. Okay, I'll just walk you through that. So you're seeing a stroke patient. What are the comments? Nobody's going to tell, go and examine this patient with hemiplegia. Okay, they are going to tell something. Examine the patient's upper limb who presented with upper limb weakness. Examine the patient's lower limb who presented with lower limb weakness. Examine the patient's face who has some weakness. All right, look at the patient's gait and examine. That's a fancy one. You ask the patient to walk, he's going to walk with a classical circumduction gait. And some people in some recovery phase may not have that full circumduction gait, what you classically see. There can be slight difference there. There can be partial circumduction there. So you have to be very observant of that. Once you know there is a unilateral weakness or a circumduction gait or like unilateral weakness in the upper limb or the lower limb, just go through quick examination, very quick and very fast examination, including the gait. And once you have done focusing on the focus is going to be if they are giving you upper limb and the lower limb examination, gait and the complete lower limb examination, upper limb examination, complete upper limb examination, and if possible time is permitting, gait. And then once you have done these things, okay, for example, in the lower limb, or look at the gait and examine. Once you've done the gait, establishing the plantar, just go up, quick motor examination of the upper limb, at least the pronator pronator drift, Hoffman, check the pulse for atrial fibrillation, ask for the blood pressure, check the carotids, auscultate the carotids, look at the facial nerve, quickly raise the eyebrows, close the eye tight, close the eyes tight, grin the teeth, blow the cheeks, check the pupils quickly. Once you have done that, then immediately just you can turn to the examiner and ask. I always tell that in the neurology station, I'd like to know since how long this patient is presenting this way. You can ask the examiner. The examiner is bound to give you an answer. He will tell you like few days back, few weeks back, whatever it is, he's bound to tell you. He cannot hide that from you. You deserve to know the answer. So you should have the idea that you can ask the examiner. Once you get the answer, you will know what it is. These are the quick things you have to do for a stroke. If you're just going to examine the upper limb, okay, done. That's it. That's going to harm you. So typically, if you practice well, 5 minutes is enough for any clinical examination, PACES examination. 5 minutes, more than enough. Okay. I hope that helps, doctor.
Yes, doctor. Thank you so much for this focused examination sequence. If our candidates perform the examination following...
Yes, yes, doctor. And yes, exactly. And one more thing I forgot, like is fundoscopy you have to offer here. Yeah.
Okay. So if our candidates perform the examination following this structure with confidence, it's going to be a clear pass without any doubt. So stroke syndromes are an important concept in neurology, and understanding them is crucial. So can you please highlight the stroke syndromes that a candidate must be aware of, doctor?
Yes, the candidate, before knowing the stroke syndrome, they should know the basic anatomy of midbrain, pons, and medulla. Okay, because I'm not going to sit here and talk about the entire anatomy. You should know what is midbrain. Midbrain, if you typically, I'll just tell in a very small, just for a few seconds, it's the initial part of the brainstem that connects the pons and the forebrain. Everybody knows the parts are, tectum, your cerebral peduncles, which includes your crus cerebri, tegmentum, and substantia nigra. Okay, there are some nuclei, motor nuclei of oculomotor nerve in the midbrain, and there is an accessory motor nucleus of oculomotor nerve, that is Edinger-Westphal nucleus is in the midbrain. There is a nucleus of trochlear nerve, mesencephalic nucleus of trigeminal nerve, the red nucleus, substantia nigra, and periaqueductal gray matter. All these things are there in the midbrain. So there are two tracts. The ascending tract and the descending tracts are there in the midbrain. The ascending tracts are your superior cerebellar peduncle, medial longitudinal fasciculus, spinothalamic tract, medial lemniscus, trigeminothalamic tract, and lateral lemniscus. The descending tract are corticospinal pathway, corticobulbar pathway, and corticopontine pathway. I know this is boring, but you have to listen to this. If you don't know this anatomy, you won't understand to localize the stroke. All right. So what are the functions? Eye movements, your ocular and auditory reflexes, your breathing, pain modulation, mood regulation, enables the passage of the major ascending and descending tract pathway. All these are important functions of the midbrain. Okay. So you may get a case like this. Somebody coming with you, for example, we can discuss it like a case also. Miss Meera coming with, some diplopia, which is sudden in onset. There is weakness. A right pupil is difficult to visualize due to low overhanging eyelid and displacement of the eye in the temporoinferior direction. And she also has some flaccid weakness on the left arm and the left leg with an upgoing plantar. So we will be thinking like, what is this? One side there is a cranial nerve deficit, on the opposite side there is a hemiparesis. So this is a classical Weber syndrome. This is one of the very important midbrain syndrome everyone should aware of. There will be ipsilateral cranial nerve palsy, contralateral hemiplegia. This is due to occlusion from posterior cerebral artery and paramedian mesencephalic branches of basilar artery. Okay, it can be due to tumor, any demyelinating condition. There is something called Benedict syndrome. This is due to occlusion of branches of the posterior cerebral artery, perpendicular perforated branches of PCA especially. Here, if it's affected, oculomotor nerve fasciculus will be affected. Red nucleus is affected. So once the red nucleus is affected, there will be abnormal tremors will be there. The rubral tremors will be there. We have videos on tremors, I believe, in the YouTube where I had shown you what is a rubral tremor. That's a tremor of the red nucleus. Okay. So there, what will happen here? There will be ipsilateral cranial nerve 3 palsy, contralateral abnormal movements of the limbs. Unlike the weakness which we see in the Weber syndrome. Abnormal movements involves like, it can be a coriform movement, it can be resting tremors like, Parkinson's. Right? Because if the infection affect the substantia nigra, Parkinsonian features can be seen in Benedict syndrome. There is another syndrome called Nathaniel syndrome. It's due to occlusion of the perpendicular perforated branches of PCA. Here, the lesion will involve third nerve nucleus or its fibers superior cerebellar peduncle before the decussation. So, what happens here? Patient will present with ipsilateral third nerve palsy and contralateral gait ataxia. One side there will be third nerve palsy, and the other side there will be gait ataxia. Okay. Then there is another syndrome called Claude syndrome. What is a Claude syndrome? It's a combination of both Benedict and Nathaniel syndrome. Here, the patient present with typical ipsilateral third cranial nerve palsy and contralateral ataxia. Along with the ataxia, there will be resting tremors and chorea due to the effect on red nucleus. I hope that clears. Now we will come to the medulla. Medulla oblongata is a terminal part of the brainstem located between the pons and the spinal cord. The nuclei are cranial of 9 to 12, you know that. Inferior salivatory nucleus, spinal nucleus of trigeminal nerve, solitary nucleus, nucleus ambiguous, dorsal nucleus of vagus, nucleus of accessory nerve, nucleus of hypoglossal nerve, everything is there. And there is a relay nucleus, that is gracile nucleus, cuneatus, arcuate, and olivary nucleus is there. And there are reticular nucleus like Raphe nucleus, gigantocellular, magnocellular nucleus, perihypoglossal, that is a Rolls nucleus, lateral reticular nucleus, and many other small clusters of neurons distributed throughout the base of medulla. So, what are the tracts? Medulla has a corticospinal pyramidal tract, cuneate fascicle, gracile fascicle, and medial lemniscus, spinal tract of the trigeminal nerve, spinothalamic tract, spinocerebellar tract, inferior cerebellar peduncle, and MLF. All these tracts are there. So, what is the function? It innervates the viscera of the head, thorax and abdomen, heart rate, blood pressure regulation, especially vasomotor center, breathing regulation, that is the respiratory center. All these are under control of the medulla. So what happens here? Okay, for example, you are getting a patient, right? Maybe a Dave, a 63-year-old male is coming with unsteadiness of gait, dizziness, dysphagia. There is a right-sided Horner syndrome, nystagmus, loss of pain and temperature on the left side of the trunk and in the left arm and leg, and there is a gait ataxia. You know very well this is something you will commonly see in your A&E intake. Typically, patient will be already sitting with a NG tube. Lateral medullary syndrome, yes, that's a very important syndrome. Okay, mostly it's due to V4 segment of the vertebral artery. Second is pica. Then vertebral artery dissection is very common in younger patients. You know, all this chiropractors and all the spa, they just turn the neck like that, and they just create attractive advertisement and commercials to lure the people in. Once you go there, this traditional bone setters can twist your bone in any way. So lesion typically involve inferior cerebellar peduncle, spinothalamic tract, nucleus of cranial nerve 5, cranial of 9, 10, vestibular nuclei, descending sympathetic fiber, nucleus ambiguous, and nucleus tractus solitarius. Signs and symptoms: patient presents with ipsilateral vertigo with nystagmus, hiccups, dysphonia, dysarthria, dysphagia, Horner syndrome. There can be ipsilateral ataxia with a tendency to fall on the affected side, ipsilateral sensory loss on the face, and there can be trismus as well. This everyone knows, Wallenberg syndrome. There is another syndrome which you should be knowing is called, medial medullary syndrome. Everyone knows lateral medullary syndrome. They should know the medial medullary syndrome. This is due to occlusion of the paramedian branches of the anterior spinal artery or vertebral arteries with ipsilateral vertebral artery dissection. Incidence is less than 1% compared to all the ischemic strokes. What happens here? If the lesion involves corticospinal tract, lesion typically also involves medial lemniscus, hypoglossal nerve, which is located in the caudal part of the medulla, are damaged. There can be damage to inferior olivary nucleus and nucleus ambiguous itself. So what happens? What differentiates it from lateral medullary syndrome is there will be contralateral hemiparesis here. There ataxia, here hemiparesis. There will be decreased proprioception and fine touch vibration on the contralateral side. The tongue deviates to the same side of the lesion. There will be dysarthria, dysphagia. Okay, this can be seen in bilateral medial medullary, in fact, with dysarthria and dysphagia. Okay, I hope that helps. Now coming to another syndrome that involves the other part is the pontine syndromes. So some basics about the pons. Okay, some basics about the pons. Just the very basics I'm going to tell. Pons is the middle portion of the midbrain. Okay, brainstem. I mean, like brainstem between the midbrain and the medulla oblongata. So you should know what are the cranial nerve nuclei in the pons. There can be sensory nuclei of trigeminal nerve, motor nucleus of the trigeminal nerve, nucleus of the abducens nerve, nucleus of the facial nerve, superior salivatory nucleus, inferior salivatory nucleus, vestibular nucleus, and cochlear nuclei and solitary nucleus. All are part of the cranial nerve nuclei of the pons. There are other nucleus, pontine nucleus of the lateral lemniscus, nuclei of pontine reticular formation, pedunculopontine nucleus, laterodorsal tegmental nucleus, and locus coeruleus. All are parts of the pontine nucleus. The tracts in pons, there are 4 different type of tracts: transverse, ascending, descending, and complex. The transverse tracts are fibers of cochlear nuclei, transverse pontine fibers. The ascending tracts are medial lemniscus, lateral lemniscus, spinal lemniscus, trigeminal lemniscus, and superior cerebellar peduncle. The descending tracts are corticospinal, corticobulbar, and corticopontine tracts. The complex tracts involving pons are your MLF and central tegmental tract. So what is the function? It innervates face, head and neck, muscles of mastication, eye movement, hearing, balance, breathing regulation, the respiratory center, transmission of major ascending input and motor descending in output pathways. So 2 more syndromes only we are going to see here. There is a pontine syndrome called lateral pontine syndrome or Mary-Fox syndrome. It's due to the inclusion of ICA, anterior inferior cerebellar artery. What happens? Cranial nerve nucleus, like, cranial 5, 7, 8, spinothalamic tract, sympathetic fibers, and middle and inferior cerebellar peduncles are involved. What happens? There can be ipsilateral facial palsy, decreased lacrimation, decreased salivation. There will be diminution of taste in the anterior two-thirds of the tongue. There can be vomiting, vertigo, nystagmus, and decreased pain and temperature on the ipsilateral side. Sensory neural deafness if the labyrinthal artery arises from ICA. Decreased pain and temperature on the contralateral side will be there. Ipsilateral Horner syndrome will be there. Ipsilateral ataxia and dysmetria can be there. So this is Mary-Fox syndrome. There is one more syndrome which you should know is Perinard syndrome. The cause of the Perinard syndrome is pineal gland tumor. It's the most common cause. Pineal gland tumor can go ahead and it can compress the dorsal lateral rostral midbrain at the level of superior colliculus. As a result of this compression, what will happen is the gaze center which is there will get affected. There will be conjugate upward gaze palsy. There is a type of nystagmus called convergence retraction nystagmus on attempted upgaze. The pupillary light reflex is lost. There will be lid retraction. It's called Collier's sign. There can be skew deviation. All right. This is called Perinard syndrome. And if anyone knows this much of syndrome, it's more than enough. And there is some locked-in syndrome. You all know that due to bilateral, occlusion of the basilar artery and metabolic demyelination and other stuff. I hope that helps. We have extended this in little depth. Okay. All right.
That was actually a very simplified version of a complex topic, Doctor. Now, I think everyone are aware of the stroke syndrome. For some candidates, it can be quite overwhelming. Just revise the anatomy, get back and listen to this again, and you will know the concepts very well. We often hear the term PROM while dealing with the topic of stroke. Doctor, could you please explain what it stands for and its relevance?
Okay. In PACES setting, the PROM came to prominence when there is a PACES center where the examiner asked a candidate, what is a PROM? He was having no idea. PROM, people know what is a PROM. PROM we do in college functions and stuff. The candidate was just like standing and rolling his eyes. He had no idea what is that. Okay. Is there any, what he is actually trying to ask? PROM means patient-related outcome measures. Okay. So what is going to be outcome of a stroke? If a patient gets a stroke, how is he going to survive and how things are going to be for him based on the patient? That's called PROM, simple as that. So there are 2 scales, Rankin index, modified Rankin index, and Barthel index. That's it. Modified Rankin scale, somebody called, and Barthel index. Just know the names, know what are the components in that. That's more than enough. That will actually help you. Okay. Yes, doctor.
Yeah. Thank you, doctor, for this explanation about PROM. Those who didn't know this before can now learn about it. Moving on to our next important concept. Doctor, what are the current guidelines around blood pressure control in stroke? Can you please walk us through the BP targets in the management of stroke?
Yeah, BP targets we have already seen. I'll just tell a couple of things about the BP target. Okay, do not offer any kind of rapid lowering of blood pressure in patient having a underlying tumor or AV malformation, or if the GCS is less than 6, or the patient presenting with massive hematoma. The ones who are awaiting hematoma evacuation, don't offer any kind of rapid blood pressure lowering regimen. All right, antihypertensive therapy is considered only in the case of people with one or more serious complaints. Who are they? Hypertensive encephalopathy, hypertensive nephropathy, hypertensive cardiac failure, myocardial infarction, aortic dissection, preeclampsia. All right, I hope you got the list. Then blood pressure reduction, ideal 185 on 100, be considered for thrombolysis. These points, more than enough.
Thank you, doctor, for shedding some light on this BP control in stroke.
Absolutely.
Before we conclude, could you please share with us the recommended blood sugar targets in the management of stroke, and why maintaining optimal glucose level is important in these patients?
Yeah, optimal blood glucose level should be maintained in any stroke patient for the better patient outcome. So the blood sugar should be always kept between two values, 4 to 11 millimole. That's the candidate has to remember that. Even in acute setting, this is what they should remember. 4 to 11 millimole per liter is more than enough. Okay.
All right. That brings us to the end of today's episode on stroke. Thank you, doctor, for all the valuable information you gave us about this topic. You have simplified various concepts in stroke for us, and I hope our listeners have found this discussion very informative and practical and will apply this for their PACES preparation.
All right. Thank you so much, doctor. It's nice to see you. And candidates like who are awaiting for PACES examination, you are more than welcome to join our weekend free webinars conducted by myself and Dr. Rathod. And we have our free sessions coming in Dubai, in Jeddah, and Ireland, and as well as in Egypt. You guys, if you're around the territory, you can just pop in there, say hi to us. It's just a free session. We're not aiming to get a lot of patients, but we are aiming to interact with you and help you out with your learning. It's absolutely free. You can walk in, and we will let you know the venue and other details shortly in our groups. All right. Thank you. Thank you so much. It's nice to see you, Dr. Sophia, after quite a while. And we had an excellent discussion on stroke. And we will catch up with another podcast in other subjects shortly. Thank you. Thank you so much.
Yes, doctor. That's a very exciting opportunity for people residing in Dubai and Jeddah. So you can meet and then discuss and then know cases for PACES as well. So clear and structured approach is what PACES needs. Apply your knowledge and understanding into practice. Keep revising and discussing with your fellow doctors. I'm sure you'll not just clear PACES, but score. For those who haven't listened to our previous podcast episodes on neurology, respiratory, cardiology, and communication stations, please log into pacesdiaries.uk. You'll find notes, examination sequences, and everything you need for your PACES preparation. You can also listen to our podcast episodes and watch videos on clinical examination sequence and techniques on youtube.com. We'll be back again with another topic to discuss. Meantime, keep practicing, take care, and bye. And thank you once again, Dr. Moses, for joining us today.
All right. Thank you, doctor. Thank you so much. Have a great day. Bye-bye.